Good afternoon, everyone. Good morning, depending on where you're finding yourself, and welcome to this Link and Learn session organized by the South to South Learning Network. And this session is around peer education in key population programs. So we'll give it a couple of more minutes for people to join us, and then we'll get started. And as we're getting started, please pay attention to three quick instructions. So as it's written you can see on your screen, we're curious to know who you are. And so please, in the chat, if you can, say hi, but let us know also where you're from. And you can click the world icon for translation. If you see at the bottom of your screen, you can click and there should be translation for French, for those of you who speak French. Donc, on a traduction en français pour les personnes qui ne parlent pas anglais. Il faut simplement cliquer sur la petite image là, du monde qu'il y a au-dessus de vos écrans. Merci. And there will be a dedicated sessions for question and answers at the end of the presentations. We have 3 presentations planned today. And please raise your hand if you'd like to speak during the discussion. There is possibility to do that by using the reactions icons at the bottom of your screen and pick the raise hand function. Thank you so much. I'm just looking for some guidance from our SSLN colleagues. Shall we start? Do we want to start with introducing the topic or shall we give it a few more minutes?
Matteo, I think we can wait just 3 more minutes.
Okay.
That's okay.
That's fine. Thank you. Welcoming people. Welcome to this session, Link and Learn session organized by the South to South Learning Network. And the topic is peer education in key population program. We have a very, very interesting session for you today. As we wait to get started, please, in the chat, you can introduce yourself, say hi, tell us who you are, where you're from. And, if you do not speak English, or would like translation in French, you can just click at the bottom of the screen. There is the world icon, like a little globe. You click on it and you pick French translation. And if you wish to speak at any point during the Q&A sessions, please use the reactions icon at the bottom of the screen and select raise hand as the function.
Okay. We can go ahead and start, Matteo. Thank you.
All right. Thank you so much, Lulama. And okay, so let's get started. First of all, once again, welcome everyone to this webinar, to this Link and Learn session. That's how we call it. It's organized by the South to South Learning Network, and it's also facilitated in this case by me. My name is Matteo Cassolato. I work at the Global Fund in the CRG team as a key populations advisor. So as I was saying, we'll be together for the next hour and a half, 2 hours, and we'll really be looking at peer education for key population programs. And I guess why, I mean, is the question that comes to mind. Why did we decide to dedicate a Link and Learn session to this topic? Well, first of all, the time is right in the sense that many countries are now engaging in the process that leads to the writing of funding requests to the Global Fund. And for this reason, we wanted to dedicate a specific session on one of the key strategies for key populations programming, that is, of course, peer education. Now, peer educators in general are, you can say, the first point of contact of between beneficiaries and program implementers. And really, we see a lot of programs that really base their entire community strategies on the figures of peer educators. So we thought it might be really good opportunity right now to have a session to reflect collectively on what is the global guidance saying around peer education. And we'll hear directly from Parinita Bhattacharjee on this particular topic. We'll also have some country examples. One from NASCOP in Kenya, who will tell us about national perspective and guidance on community-led outreach. We'll hear from Memory on this. And then right after, we're also going to hear from Senyo Kobla and Egbert Bruce on the implementation of a community-led outreach in a key population program in Ghana. And so we're hoping that through these examples and also setting a bit what the global guidance says, we will be able to all together learn something more about peer educators. And I'll leave it to that and start by welcoming our first presenter here, Parinita. Please come online and take us through the first set of slides. Thank you.
Thank you so much, Matteo, and hello, everybody. When I was asked to put together a Link and Learn session on peer education, and I was like, Matteo, why should we do this in 2023, right? Everybody knows about peer education. But I was told that the timing is right. Many of the countries that you're participating from are getting into proposal writing, global fund proposal writing, COP. But at the same time, I was also told that when there's a fund crunch, sometimes this is the area where it gets cut. And so today, our responsibility is to make sure that everybody here understands that this is one of the most critical part of key population HIV prevention program. And like Matteo said, I'm going to provide some global guidance on outreach, especially looking at peer outreach workers. Next slide, please, Mo. As you all know, we have a package, consolidated guidelines on HIV, viral hepatitis, and STI, prevention, diagnosis, treatment, and care. And this is a package of services that WHO has revised and launched in 2020. So it's very clear in the package that there is an essential package which has direct impact on HIV. But then this essential, if there is no enabling environment, and here is a package for enabling environment, or other areas which affect broader health, which could include anal health, mental health, etc. So while we can focus on HIV testing, harm reduction, PrEP, if we don't provide enabling environment for programming and do not link up with broader health, then the health intervention may not have its impact. So the package is very clear also that community-led outreach and peer educators, peer navigators, however we call it in different countries, are a very critical part of implementing this package. Next slide, please. In 2014, WHO, UN, in partnership with KP Networks, also published these implementation tools. There is sex work implementation tool, MSM implementation tool, trans implementation tool, and drug users implementation tool. So while WHO guidance provides the what, these implementation tools provide practical advice on how do we implement the package. And these tools are available in French, English, Russian, and Spanish, and it's available in the HIV Prevention Coalition website. But if you even Google it, you'll find it in various websites. So I would urge you all to read these guidelines because they provide a lot of information on how do we implement the package. Next slide, please. There is another global guidance, which is called Key Population Trusted Access Platform. And this is also a very good guidance to understand what are these trusted access platform. And if you press it again more, it also provides guidance on engaging community with continuous key location presence and strengthening outreach, including microplanning. So this is another global guidance to refer to when we're talking about key population-led outreach. Next slide, please. And the last one over here is the guidance on virtual HIV interventions. Currently, this has been quite a bit of discussions about key populations moving from the physical space to virtual space to look for partners, etc. So this guidance provides information on how KPs can be reached in virtual spaces through peer facilitation. Next slide, please. So what do we mean by community-led outreach? So what we mean is that there is a main personal interface between the program and the majority of the community. And outreach is that interface through the community outreach workers. Community-led outreach also means promotion of services and referral. It could HIV testing, counseling and care, etc. And it is also an entry point to strengthen community leadership, provide community-led crisis response and other structural interventions. Next slide, please. So community-led outreach simply means reaching out to key populations by key populations at their preferred location during preferred times with programs and services to address their needs rather than waiting for them to show up in our clinics, offices, or drop-in centers. Next slide, please. Why is outreach important for key population? It's because services and programs are not always accessible for key populations. Sometimes they're not available at the right time and the right place where key populations want. Often key populations are new to an environment, mobility, migration, etc., and may not be aware of local programs and services available in that city. There is stigma and violence. We all know about it. And because of that, sometimes key populations do not access services. There is also the risk reduction commodities, whether it is condoms, lubes, or injecting equipments that may not be available in all locations, especially where risk takes place. And that's when it's important to outreach to those locations and provide those services. And of course, vulnerability factors are intensified at the locations where key population members work, stay, inject, or cruise. And if services are not available, even to address crisis in those spaces, then it can act as a barrier to access the health services. Next slide, please. And why should outreach be led by a community? Because a program's perspective many a times is very, very different from the community perspective. And any outreach, if it has to be successful, it should be based on needs and experience of key populations and not what program think key populations need. And key populations understand their needs the best. And that's why we say outreach should be led by community. And community-led outreach is also important because the focus of outreach should be also empowering key populations to protect themselves rather than considering them as targets. And of course, community-led outreach also stimulate community empowerment and create a collective identity, which a project not led by the community outreach workers or community team, it cannot create that collective identity. Next slide, please. Of course, you all know what are the key principles of successful outreach, and it does include credible, trusted outreach personnel, the peer educators, And if we have non-community members, then they should be trusted, oriented to community situation and needs, right time, right location, should have very clear objectives. Why are we doing that outreach? Maintain confidentiality. It's very important. Our communities are largely criminalized in most parts of the world. Understand the heterogeneity within the community. Our key population community is not a homogeneous group. There are heterogeneous needs, whether it could be based on gender identity, could be based on age, could be based on typology, where people cruise or seek clients. And any outreach process should, in true sense, be led by key populations and should be empowering for key populations. So there are 4 steps in the global guidelines that details out how to implement community-led outreach. Step 1 is about mapping the community and designing an outreach team. Step 2 is recruiting and training the outreach team. Step 3 is conducting micro-planning to implement, manage, and monitor effective outreach. And step 4 is fostering leadership opportunities for the outreach team. Next slide, please. So in the global guidance, most of the guidance talks about the need for mapping the community. So many countries and most countries should do key population size estimation, but the key population size estimation doesn't necessarily always involve community. And sometimes the size estimation, which are very, very important, can be done at the national level or at the subnational level, but doesn't always sometimes reach the spots, the locations where our key populations inject drugs or cruise or do sex work. So it's very important to map both the physical and virtual locations where key populations meet their sexual partners or inject drugs. And that mapping should be in partnership with key populations. There are several tools that are available, and I've given some examples of some tools that are available, which are visual, doesn't need too much of literacy levels if that's a challenge within the community. But mapping can also be accompanied with consultation to understand needs and preference of key populations. And this kind of reliable data, because it's community data, is very, very meaningful. And it provides, helps the program to provide acceptable and accessible services to the greatest possible number of key population. But this process also helps to build for a new program that's coming to a new site, also helps them to build rapport with the community and identify an outreach team. Next slide, please. So based on the mapping findings and the estimation in each of the locations, virtual or physical, a community-led outreach system can be developed for the program, ensuring that the outreach team has continuous presence in these locations. Normally, an outreach structure, it's different in different countries, but normally an outreach structure includes peer educators, they're called peer outreach workers in some places, who are generally part-time, and then peer supervisors or outreach workers who are most of the time full-time, and they are a supervisory cadre. In many countries, there could be other cadres like micro-planners or other outreach team members, but these are minimum 2 cadres that a program needs. Peer educators. Each peer educator is selected based on their contacts from the location where they normally operate from. So if Parinita is a sex worker, she operates from location A, you will not make me a peer educator for location B or C or D. You will normally consult with the community in location A, and if I'm selected and I have all the criteria, I would be asked to be a peer educator for location A, because that's where most of my contact is. That's where I come to do sex work almost every day, and I can put 1 or 2 hours education, because remember, peer educators may not be a full-time job. Sorry. Each peer educator is allocated locations where they take responsibility to support the key populations in those locations. Next slide, please. While we select peer educators, it's also very important to look at peer ratio. And sometimes in some places, peer educators are like floating peer educators. They identify key populations and then they register them in the program, and then they go and identify new key populations, which is great. But it's ideal that a peer educator is responsible for a cohort of key populations that they support in a continuous basis. There's a research in Kenya which shows that the peer educator to a peer or a key population ratio for sex worker, if it is one peer educator for 90 or less than 90 sex workers, and for MSM, if it is one peer educator for 60 or less than 60 MSM, then the outcomes, whether it's outreach, whether it's clinical attendance outcomes, are much better if it is, as I said, for FSW, if it is below 690, and for MSM, if it is below 60. If it is higher than that, then the intensity of interaction and intensity of outreach is compromised. Next slide, please. The guidelines also clearly define what's the role of a peer educator and what's the role of a community supervisor or an outreach worker. And I won't go into detail because the presentations after me, Memory and Sanyo, are going to talk more about it in a practical way. Next slide, please. The second very critical part of outreach is recruiting, training the outreach team, right? So once we do the mapping and consultation and terms of reference are developed, and there are guidelines for recruiting, retaining, and assessing and promoting outreach workers. Outreach workers, peer educators can be very easily recruited, but training is a very, very important part of building a strong outreach team. And if there is standard training curriculum, and training is not only one time, there is main training and then the refresher training, then it's very easy to cascade. If you are scaling up a program and you have a curriculum, then it's very easy to cascade these training. Involvement of key populations is important in recruitment, and I have said that before. If you, I as a sex worker, am I operating in location A, then you do engage with people in location A to understand if I would be a good peer educator. Remuneration, and I'm going to talk a little bit more about remuneration. Remuneration is very important. This is not free work. So somebody is leaving one or two clients to do this kind of peer education. So remuneration is important. Obviously, remuneration has different levels. If you are a part-time, the remuneration will be different. But if you're a full-time outreach worker, you should be a salaried person. And obviously, you don't want to stay as a peer educator forever. If there is interest and if there is capability, there should be also plans to do peer progression and retention. Next slide, please. These are several qualities of outreach workers. You should be an active key population member if you are going to be a peer educator. Ideally, even in the context of PWID, we say that if you're active drug user, it's better because you understand those communities better. You come to those locations all the time to either practice sex work, cruise, or to use drugs. So it's ideal if you are active, if a peer educator is an active key population. But if you're an outreach worker and it's a full-time job, the guidelines of population member. If you're not a very active person, it's all right, but you should have been a key population at some point in your life so that you understand the realities. You should be knowledgeable about local context, especially the location. Ideally, you should be operating in that location. There should be a good social network. You should be accepted by other key populations in that locations. And of course, you should be committed to the key populations. As much as you are a peer outreach worker or an outreach team is hired by the program, the accountability of the outreach team should be to the key populations along with the program, right? So the outreach worker should at any point of time think about what is good for the key populations. You should maintain confidentiality. You have good leadership skills and listening skills. And again, I think Sanyo is going to talk a little bit more about how they do it in Ghana. Next slide, please. So the guidelines talk in detail about remuneration, and they do talk about options for remuneration. There's salary is an option, but there are also stipends that can be provided. There should be provision for travel, provision for mobile airtime, right? So those are also options that are possible to provide remuneration. However, the sex worker implementation guideline very clearly says that community outreach workers should always be remunerated for their work, right? However, certain approaches may be problematic. For example, paying community outreach workers for each individual they persuade to come to the clinic or drop-in center for services can distort the demand and lead to coercion. So this whole incentive-based remuneration is discouraged. You bring one key population to the clinic, you get whatever, $1 or 200 shilling. So that is what is discouraged. It is what is encouraged is that a peer educator is responsible for a cohort of key populations in a specific location, and they get remunerated for supporting that cohort on a monthly basis, right? But less coercive or more or effective incentives. If you have to give incentives on top of remuneration, then it could be non-monetary gifts, leadership opportunities, phone credit, etc., right? Which is not linked to individual sex workers who are brought to the program. Next slide, please. Now, once the outreach team has been identified, consulted, recruited, and trained, microplanning becomes an important part for the outreach worker as tools to implement, manage, and monitor effective outreach. And it's because, as I said earlier, the key population is not a homogeneous group, and they have different needs, and hence our outreach needs to be differentiated based on typology, client volume, age, timing and day of operation, gender identity, duration in sex work, type of sex, experience of violence, alcohol use. Some of these also increases people's risk or vulnerability. Research shows that key populations who are younger experience more risk or vulnerability or violence, or key populations who have experienced or who take alcohol or are dependent on alcohol or have problematic alcohol use also experience high violence or cannot adhere to some of the treatment or services. So microplanning helps to understand within a peer educator's cohort what kind of key populations are there, what are their needs, who needs more attention, who can actually maintain without so much attention, so that the peer educator can plan based on the needs and the profile, a differentiated outreach for each of their key populations in the cohort. Next slide, please. And I won't belabor on this too much, but microplanning also decentralizes outreach planning and management and monitoring. So microplanning helps the peer educator and outreach team to plan and become managers for their site. So it's not the program saying, oh, go and meet this X and Y key population or Z key population. It is the outreach worker and outreach team deciding that they're going to meet X because there is this kind of a issue with the X, right? So they're no longer passive data gatherers, but active site managers. And they also, microplanning also helps the outreach team to identify gaps in the outreach efforts and empowers them to address these gaps. Next slide, please. And these are some of the tools that microplanning tools that the outreach team uses. And I think some of this will be shared by Memory and Egbert a little later. Next slide, please. Of course, the key consideration of any mapping, consultation, microplanning is that data safety is critical. We do not work with criminalized population, so there are always there's always fear data being leaked out or being misused. So data safety is very, very critical. It's not one-off activity. Outreach is not a one-off activity, but it's a continuous activity and needs to be routinized. And the data generated from microplanning should link with other service data. So it's not the outreach and the clinic team don't work in silos. And microplanning needs to be integrated within program management processes. Next slide, please. And as we work with outreach, it's very, very critical to foster leadership among the outreach team, and they should be provided training and mentoring and opportunities to learn new skills. Peer progression is very important, opportunities for program management and leadership roles, and of course, involvement in program monitoring and planning itself becomes very, very important. And it's laid down very, very clearly how this can be done in those global guidance that I shared. Next slide, please. So in conclusion, community-led outreach is an essential link between the community and the HIV prevention care and treatment program. It empowers key populations to draw on their first-hand knowledge of vulnerability and risk to problem solve with members of their community and strengthening access to services for those community members. Microplanning is a key process that empowers the outreach team to develop differentiated outreach plans for each key population. Continuous capacity strengthening, peer enumeration, and peer progression is critical. So peer educator to peer ratio is important for effective coverage, and a cadre of supervisors to provide supportive supervision to the peer educators do improve the quality of outreach process. And last but not least, accountability of the outreach team towards the community and the program is also an essential part, and the program can do a big thing to kind of facilitate and enhance that accountability of the outreach team. I think the next slide is thank you slide. Thank you. And over to you, Matteo.
Thank you, Parinita, for this really, really great overview of, peer education outreach really work. And really, to me, I really, really appreciate the strong emphasis on community leadership, on the fact that we need ownership, because it really empowers key populations. And as you said, key populations are not one homogeneous group, right? There are different needs, and really, so empowering them and having them lead really simplifies our lives as planners in the beginning, but also really empowers communities to provide services to their own peers. I also really like the fact that you touched on aspects like as remuneration, for instance, which is one of the aspects we normally try to shy away because particularly complex endeavors. And also I really liked that you spoke about career progression, right? And trying fostering leadership among peer educators, because I really think that that's one important question that we're being asked, in terms of, okay, what happens next, after someone becomes a peer educator. So really, thank you so much for this. And without stealing too much of your time, I'm just going to go to the next, to invite the next speaker here. We're having Memory Mellon from the National AIDS and STI Control Program in Kenya. And please take it away. Thank you so much. And we're all ears.
Thank you so much. So I'll take you through the community-led outreach and peer education. And this is going to be basically a Kenyan experience in terms of how we do it in our country. And this is a presentation that we worked on together with my colleague, Janet Musimbi, who is also a technical coordinator within the HIV Prevention Technical Support Unit, and working together with NASCOP and the National Syndemic Disease Control Council. Next slide, please. So as a country, we are guided by the HIV prevention roadmap. And the main goal of the roadmap is really to end AIDS as a public health threat by 2030. And just looking into this slide, it basically tells us that HIV is disproportionate within specific populations as well as specific geographies. So as a country, our current prevalence of HIV is 4.0%, but you can see the female are really bearing the brunt of HIV at a percentage of 5.3% as compared to their counterpart, which with a prevalence of 2.6%. And again, just to mention that in terms of geography, we have really within the 47 counties of Kenya, we have counties where HIV is quite high in terms of the prevalence, as high as 16.2% in Homa Bay County, and as low as 0.2% in northern areas of the country, such as Wajir sub-county. But also to mention that the adolescents and young people, when you look at their contribution to the new HIV infections, we find that they attribute to 34%, and that is the age category of 15 to 24 years. And remember also we have young populations within this cohort. And we did a transition study in Kenya back, and actually it indicated that young populations have very limited access to HIV services. So of course, also the young populations within the within the AYPs also really needs to be focused on. And as a country, overall, we are saying that you have around 1.4 million people living with HIV. But again, the new HIV infections are quite high between the ages of 15 to 34 years, which is actually attributing to 64%. Next slide, please. Now a bit specific on key populations. We are seeing that the prevalence, the incidence, as well as the estimates of the key populations in the country is actually quite high. And this is quite high as compared to the general population. If you look at the prevalence, for instance, for the key population is 4 times higher than the general population. Of course, really drawing the need to focus on the key populations, and the numbers are actually increasing. Looking at the estimates that you conducted in 2012 as compared to those of 2020. For instance, you can see the female sex workers in 2012. In 2012, key population size estimation, we had around 130 female sex workers, but currently we are talking around 200,000 female sex workers in the country. The good thing, and anyone would ask as a country, that do we know where our key populations are? And the answer is yes. And this is depicted also if you look at the maps that is actually showing the different key population typologies. That is the female sex workers, the people who are injecting drugs, the transgender, and the men who are engaging in sex with other men. So we are aware of the locations of the key populations in terms of the density. And you can see, especially in areas where we have the orange, that is where we have a high number of key populations. In areas where we have the yellow, seemingly we have medium numbers, and of course now we have fewer numbers in certain locations. And again, most of this is done by the key populations themselves in terms of really going to those hotspots and getting to know these numbers. And as a country, this has really helped us in terms of targeted programming for key populations, as well as even resource allocation for different counties based on the numbers of key populations within those counties. Next slide, please. So as a country, in terms of our epidemic, we are talking about generalized epidemic, we are talking about concentrated epidemic, and of course, mixed epidemic typology. Of course, depending on the populations that are really attributing to the high HIV incidences. And really, of course, for the concentrated epidemic, we have mostly the subpopulations with high risk behavior, such as key populations, attributing to majority of the ongoing risk. But what I want to mention here is that regardless of the epidemic typologies within our country, being that key populations are at high HIV risk, then that does not defer reaching out to them. And that is why, as a country, key populations for us is a priority population within all the 47 counties. And again, our policy document, which is the Kenya AIDS Strategic 2, identifies key populations really as a priority population for HIV response. And of course, considering the high prevalence that I talked about, the high numbers that you have currently, the high incidence, and not forgetting to mention that even as a country, activities such as sex work, drug use, and engaging in same-sex relationship are equally criminalized. Next slide, please. So as a program in Kenya, the key population program is both within the national government as well as the county government. At the national government, the key population program is led by the Ministry of Health under the leadership of National AIDS the State Control Program, that is NASCOP, and the NSDC, which was formerly NAC. And at the county level, we have the County Ministry of Health spearheading the key population program. But at the same time, the approach that you're using when it comes to service delivery to the key populations is the evidence-based approach, which is the combination prevention approach that really addresses all the three components of biomedical interventions, behavioral interventions, as well as the structural interventions. So the key mandates at the national level in terms of NASCOP and NAC is mainly really to provide strategic direction, really giving standards in terms of guidelines, the manuals to be used, offering technical support, where we also have the technical support unit really embedded within NAC and NASCOP, conducting research for evidence formulation, resource mobilization, as well as creating enabling environment. But remember that in Kenya, when it comes to implementation, happens at the county level. So at the county level, also the key mandate of the county is just to ensure that the efficient and effective implementation, of course, really through the implementing partners within the county level. And currently as a county, Bing had mentioned that we have 47, as a country, we have 47 counties. Our presence in terms of coverage, we are currently covering 42 counties out of the 47 counties. But again, the goal is to saturate all the 47 counties with key population programming. And the support is mainly from the Ministry of Health. We have PEFA and Global Fund, among other donors that are supporting the program in the country. Next slide, please. We have a very clear coordination structure as pertains to key population program. And the coordination structure, of course, based on the fact that you have the national government and the county government. At the national level, we have, of course, the National Key Population Program that was established in 2009, and that was within NASCOP. And again, the National Technical Support Unit was also established in 2012, really to support the National Key Population Program. So at the national level, we have a coordination mechanism, and this coordination mechanism is through what we call the National Key Population Technical Working Group. The same is actually replicated within the county, where we have the County Key Population Working Groups. And these working groups usually meet actually on a quarterly basis. But again, within the technical working groups, we usually have several subcommittees, depending on technical issues that are deemed to be very important, that needs to be discussed, both at the national level and at the county level. And just to mention that both the National Technical Working Group as well as the County Technical Working Group draws membership from various quarters. And of course, we have the key population members being part of those technical working group meetings. We have the donors, we have the implementing partners, of course, the Ministry of Health representative themselves, among others. Next, please. Of course, I'd mentioned that the sex work, same-sex relationship are criminalized, as well as drug possession, which is actually similar across most of the countries within Africa. But again, as a country, there's been a lot of commitment, and this has shown really prioritizing the National Key Populations Program, and of course, the 4 typologies of the key populations being prioritized within the National Strategic Plan since the year of 2009. At the same time, as a national program, a couple of guidelines have been developed. And some of them, of course, include our National Guidelines for HIV Prevention Program with the key populations that was developed in 2014. But again, also to mention that Kenya is one of the countries that was first when it came to developing of the HIV and STI programming with the young key populations. And of course, really to ensure that there's implementation and to ensure that there's coverage and effectiveness of service delivery. It really depends on the quality of peer education and outreach programs. And this is a whole section that is covered within the national guidelines for HIV programming with the key populations. Next slide, please. So for any key population program, you'll get to understand that the community outreach team, and when we talk about the community outreach team, we mainly talk about the peer educators that Pari was talking about. You're talking about the outreach workers. So this team is actually the backbone of any key population program. Any successful key population program is actually anchored on a very strong community outreach program. So really, if you want our key populations program to be successful, then we also have to ensure that we give really priority to the community outreach. We give them enough resources to carry out their work, and we really give them the necessary support that they need also in their work. So in Kenya, the peer educators who we work with, and actually also the outreach workers, who are the supervisors to the peer educators, are actually members of the key populations. And the reason why we always insist that the peer educators must always be active members of the key populations is also not to inconvenience them, so that as a sex worker, for instance, goes to the hotspot to solicit for sex, then they're able also to create some time. Of course, when the key populations are not very busy with their clients, probably to do one-on-one session with their peers or to do group sessions with their peers. And again, in terms of the peer ratios, it's quite clear in the guidance in terms of the cohort of peers that each peer educator is supposed to man or supposed to be contacting on a regular basis. So based on evidence, and again, as well as program experience, we have standard ratios. And for female sex workers, for instance, we're talking about one peer educator is supposed to be reaching out to between 60 to 80 female sex workers. Of course, we call them cohorts because for us, when it comes to key population program, you have to keep following them. It's not like an orphan survival population program where we meet a child today and then leave them and then track and get to understand maybe what was their score in school later on. These are key populations. They are engaging in high-risk behaviors. Some are being violated. So you have to walk through with them. And that is why we are saying that as a peer educator, they must have a cohort of peers that they work with through and through. And of course, for MSMs, you're talking about one peer educator to 30 to 40 MSM. For people injecting drugs, the recommendation is that one peer educator reaches to 30 to 40 PWDs, transgender people, 1 to 30 trans people. But again, also I'd mentioned that we have outreach workers, and the outreach workers, their main role is really just to mentor the peer educators and to offer supervisory role. So for the peer educators, the recommendation within the guidance is that one outreach worker is supposed to be supervising or supporting 5 peer educators. And also just to mention that as a national program, we've really worked, and a lot of advocacy has gone around with the implementing partners. And if you go to most of the programs, you'll realize that the standard PR ratios is what is worked with. And of course, we've seen a lot of success when it comes to really reaching the peers and delivery of services. So the other thing also just to mention is that we really encourage, what we encourage as well is that the outreach workers ideally, and this is what happens in Kenya, are the peer educators who have been promoted to the outreach worker level. It is a way of motivating the peer educators, especially those who are performing well. And we highly discourage having people from outside coming to work as outreach workers. We expect that if you have peer educators and these are key populations and they're working well, then there's a way that you also need to motivate them and also have them progress from probably peer educator to outreach worker. We have people who began as peer educators. Currently, of course, they move to outreach workers, program officers, and a good number of them have even established their organizations. Next, please. So basically, this is just a pictorial in terms of an organogram of the outreach structure, where we have the peer educators at the lower level reporting to the outreach workers, and then, of course, the outreach workers reporting to the coordinators. And at each level, we have tools that we are using for reporting. Next slide, please. I know Pari had talked about the remuneration for the outreach team, but currently in terms of our guidelines, it's quite clear on the amounts that needs to be paid, of course, in form of stipends, especially for the peer educators. So in the guidelines, we have for the female sex workers, the MSM and transgender programs, the outreach workers, the guidelines speaks of 10,000 Kenya shillings to 12,000 Kenya shillings. Peer educators is 3,500 Kenya shillings to 4,500 shillings. And you can also see for the people who are injecting drugs, it's clearly stipulated in terms of the amount that needs to be paid to the outreach workers as well as peer educators. But again, just to mention that what is above was based on the 2014 guidelines, which we are currently working around to review based on the current WHO guidance. But again, through a TWG decision, the remuneration of the peer educators actually changed to 6,000 Kenya shillings to 7,000 Kenya shillings, and that is what is currently being implemented by actually all the programs in the country. In addition to that, you find implementing partners also offering stipends for travel or airtime. Next slide, please. So we all understand that really for quality service provision, capacity building is very critical. So for us, capacity building is a key component of the key population program, and we have actually we have all the curriculums for the different cadres that are our key stakeholders that we need to train. And actually for the outreach team, that including peer educators, outreach workers, advocacy workers, as well as paralegals, we have defined curriculums for them. And these are national curriculums. And at the implementation level, which mainly happens at the county level, the implementing partners are supposed to be using the standard NASCOP curriculum, as well as the standard NASCOP TOTs. And for us, it's the national program that trains the TOTs, while the implementing partners at the county level now actually supports the training of the peer educators, outreach workers, as well as other cadres that you work closely with. So even for the peer educators, we have specific curriculum. For the female sex worker, we have specific for MSM, we have specific for PWD. And of course, this was also based on the fact that looking at these different populations or different cadres, then also their needs were quite different. But again, as a country, we also have a national training SOP, which stipulates that this team must be refreshed on an annual basis. And we try to follow with the programs and really to budget for refresher trainings on an annual basis, especially for the ongoing programs. Of course, for the programs that are just beginning afresh, the standard is usually that they have to train for 5 days, especially for the outreach team. But now as they proceed in terms of programming, then we recommend that they have to conduct refresher trainings on an annual basis. And again, also just to mention that we have a quarterly capacity building plan. Of course, the implementing partners share with us their plans in terms of their capacity building plans, the trainings that are planning to conduct within the quarter, we consolidate them. And then we have a tracking log, and we track these trainings. Of course, sometimes we're also able to supervise these trainings just to ensure that standards are followed. We evaluate these trainings, and the details of the participants, we enter them into a platform that we call TrainSmart, and eventually the participants are certified by NASCOP. Next slide, please. So as had been mentioned before, microplanning is very critical when it comes to peer education and outreach. And basically when you talk about microplanning, it just means that you allow the peer educators and the outreach team, that is the team at the grassroots level, so that they're able to plan for their work, so they're able to manage their work. And of course, for this to happen, the main aim of microplanning is so that you're able to reach maximum number of peers. And microplanning usually have a couple of tools, because the question that you usually ask yourself, as a peer educator, there are critical things that you must be able to understand about your peer. You have to understand the risk of your peers. You have to understand, for instance, where your peers, maybe they solicit and all that. And for you to do that, you must be able to conduct microplanning. And you have a series of tools that you usually use to conduct microplanning. And really, microplanning, the main benefits, of course, even for peer educators, you're able to cluster hotspots. The peer educator, of course, through their contact listing that had even been talked about previously, you're able to have names of your contacts within those different sites of hotspots. At the same time, you're able to understand the heterogeneity of the different key populations, as had been mentioned earlier. Really, the peak time and the peak day, because it's very important for a program to understand, as a KP, for instance, what time and what day will be the best time, or that you'll be able to reach out to our peers. So through microplanning, you're able to really know when is the best day and when is the best time, so that you're able to reach your peers, so that you don't be going to the hotspots on Monday to Monday conducting peer education and outreach. But you need to understand your peers, you need to understand the hotspot, so that you know the specific day and the specific time that you're able to meet majority of your peers and conduct peer education and outreach. Of course, also understanding the risk of your peers, and based on the risk, you're also able to understand their commodity requirements, so that even as you provide those commodities, you provide the commodities based on the requirements. So we have a couple of tools that you're using. We have what is called sideload mapping, and for sideload mapping, it's basically just a representation of the sites or of the hotspots. And it also has the loads in terms of the numbers of the key populations in those hotspots. And really, it also helps understand how many key populations do we have probably in that particular hotspot. These are unique key populations. So it's majorly just used to profile the sites, and it helps in really planning for outreaches. We have now what you call site analysis. So site analysis is basically now really going in depth into each and every site or each and every hotspot, and really trying to understand for each hotspot, for instance, which hotspots have probably a high volume of clients, high volume of low volume of clients, or medium volume. And also this also just helps us to also plan for outreach. Of course, also really understanding their ages, amongst all that. For contact listing is very critical as well in terms of uniquely identifying key population. And this is usually important, especially when it comes to identifying the best peer educator to be reaching out to peers within a particular hotspot. There are cases where you'll find a peer educator insisting that they have to reach out to peers within a particular hotspot. But when you tell them just to list the number of peers that they know in that particular hotspot, maybe they'll just generate a list of 2 or 3 people. Then clearly we know that that's not a peer educator who can be able to reach out to peers there. Of course, we have a contact form, which is usually filled one off and just provide the key populations. We have a peer plan, which is a very critical tool in terms of understanding the risk behaviors of different individuals within your cohort, understanding their commodity requirements, among the rest. And of course, the peer calendar, which usually used on a monthly basis by the peer educators to report, and opportunity gap analysis. For peer educators, there are usually monthly meetings. So they're called monthly review meetings. Some programs call them micro-planning meetings. So they meet on a monthly basis with the program team, that is the peer educators, outreach workers, and the program team, and they just review their progress. So whenever the peer educators are reviewing their progress, one micro-planning tool that really comes in handy is the opportunity gap analysis, because each peer educator is able to tell, for instance, these are the estimated number of key populations in this particular hotspot, and these are the numbers that I've contacted, probably what is the gap, and how am I supposed to work around in terms of overcoming those gaps. Of course, also a forum where the peer educators are able to share their experiences, their best practices, so that they're also able to learn from each other. Next slide, please. So how do we ensure that there's fidelity when it comes to the guidelines, that is the implementation of the guidelines? So as a country, we have a standards for peer education, and actually have 12 standards. And this is a whole document that talks about standards of peer education, talking about management, talking about selection, retention, everything regarding peer education and outreach. And this document just helps to ensure that we standardize peer education and outreach at all levels within the country. At the same time, I talked about really capacity building and ensuring that when capacity building is being conducted, it's as per the national guidance in terms of using the national trained tutees, using the national curriculum, and also the other procedures that must be in place. Also, we do indicators, and we actually conduct indicator analysis. And some of the indicators speaks directly to peer education and outreach. And after collecting this data that focuses on peer education and outreach, this data is usually analyzed by the M&D team and usually presented during the county and national technical working group meetings. We usually have peer conversion forums on an annual basis. So during these peer conversion forums, we usually bring the key populations from all over the country. So the key populations come on an annual basis, and when they come, they share, they give us feedback, probably some of their struggles. And as a national government, we see how we can really support them. And of course, we usually have annual stakeholders meeting that is also in bringing together all the implementing partners, including the county team, sharing their best practices, learning from each other, addressing any arising issues, and all that. And of course, also donor meetings that are usually conducted. These are mainly on a quarterly basis, roundtable donor meetings, just to ensure that there's optimal use of the donor resources. And again, we usually conduct the routine data quality audits and support supervision. And we have a standard checklist that we use. So within the standard checklist, we have actually, I call them variables that just speaks to peer education. In terms of when you go for supervision, we want to check whether the peer ratios are adhered to, whether micro-planning is being conducted, whether peer educators have been trained and looking at their certificates and all that. And at the same time, we usually hold advocacy meetings with donors just to ensure that guidelines are in place and are followed. Next slide, please. So when it comes to management of peer education, I talked about the established coordination mechanism that exists at the national level and at the county level. And of course, in such kind of forums, remember these forums, we hold them on a quarterly basis, both at the county level, all the 42 counties that are currently implementing the key population programs, and at the national level. So what usually happens is that the counties usually hold their TWGs just earlier before the national TWG meetings. So prior to the national TWG meetings, the counties are supposed to be holding their TWG meetings. And then the county leads, that is the CASCOs, we call them the CASCOs, supposed to be, of course, coming to the national TWG meeting or sharing some of the discussions they had at the county level. And if there are areas that probably the national government needs to pick up, then it's done at that time. And another thing that we've also done, just to ensure that in terms of resources are optimally used, is that we as a country, we've allocated counties specific donors, so that in a particular county, we have only one donor granting or sub-granting the implementing partners. And this we did just to ensure that we deal with duplication issues and to ensure accountability. Because initially we'll have probably 3 donors in one particular county, and there were a lot of duplications and also lack of accountability. So currently, that is what we've done. And even at the county level, of course, there's one donor that is supporting implementing partners. So if you have one donor that is supporting implementing partners, and probably we have 3 implementing partners in that county, then what we do is within the county TWG meetings, we also demarcate for the implementing partners so that each implementing partners knows where they're supposed to cover and not overlapping in other areas that another partner is supposed to be covering. Of course, I talked about the quarterly donor meetings that are usually conducted. just to review progress, I talked about the annual peer convention that we do just to get feedback from the community, as well as the annual stakeholders meeting. And lastly, to mention that the technical support unit, which is embedded within the national program, that is within NASCOP and NSDCC, really is up to task in terms of providing technical assistance and support to programs, both at the national level, county level, and also for the implementing partners. Next slide, please. Thank you.
Thank you so much, Memory, for this, for this presentation. I thought it was really, really rich and dense with a lot of, information. To me, what stood out, it's really the impressive standardization and also decentralization of the KP program, right, at the county level, with having the technical working group, replicated in all of the counties that are implementing the KP program. That are practically all of them, right? It's many, many, many. So really, really good to see that. Also, great, I think, the nuancing around some of the, implementers of the KP program at the community level in terms of peer education, peer educators, but also outreach workers, and how, we have like a community outreach worker that is supervising something like, I think you said 5 peer educators. So really great also to give this dimension a bit of the different types of programs that exist. I also really like the fact that you talked about capacity development, and capacity building and training, continuous training for peer educators and people who implement the KP program at the community level. And really, I also like the insight that you provided on the microplanning tools that are used in Kenya. So really, really thank you. And I'll just now move to our next presentation. It's also the last one we're having today. As you know, we're having, this is probably a case study from Ghana, and we'll be hearing from Senyo Kobla-Wasonro and Egbert Bruce from the Maritime Precious Life Foundation. And please take it away. Thank you so much for having us.
Okay, thank you all, and good afternoon. Good afternoon, colleagues. My name is Egbert Bruce, with the JSI implemented USAID Strengthening the Care Continuum project. This project is working through local civil society organizations to implement and support the Ghana Health Service to achieve epidemic control in HIV/AIDS in our communities. So we are working with civil society organizations, one of which is Maritime Life Precious Foundation, being represented here today by Senyo Usonu. The country has champions, and the next slide, please. These champions cut across civil society organizations, donor partners, and then of course, Ghana AIDS Control Program and the National AIDS and STI Control Program. So these are the champions. Next slide. And since yesterday was World AIDS Day, let me take this opportunity to highlight the significant contributions of our women-led civil society organizations working in the KP space. Comfort Asamoah, Anti-CC in Takrade, Lucy with RAF, Anti-CC with LRF, Lucy with RAF, Trudy Nunu with EPIC, and Salome with WIO, etc. So ladies, congratulations for a great job you've been doing for KPs. So without much ado, we'll go on with our presentation, which is going to be provided by Senyo Usonu. Senyo, as I mentioned, is the Executive Director of the Maritime Precious Life Foundation, and he implements at the community level. So he is one of our key agencies working to provide care and support to KPs through his organization, and they work in several districts in the western region of this country. So Senyo will take us through HIV and KP programming in Ghana, peer education, how they do community entry, the way and manner they go about recruitment and selection of KPs, how they train the peer educators. Then he also mentioned the micro planning that they do and the tools that they have provided nationally, of course, by the Ghana AIDS Commission National AIDS Control Program. Incentivization will be discussed, as well as the monitoring and supervision needed to ensure that PEs keep to their role and then do a very good work at reaching out in the community and providing care to those who need it. And then, of course, the supporting role of government and other NGOs. And he will outline the challenges and then the way forward. So next slide, please. Senor. Next slide. Okay, so Senor.
All right, so thank you very much. Senor Koblausonu, like you said, and at this presentation, we'll be looking at the contextual overview of HIV and KP program in Ghana. And Ghana, for instance, as a country, we have a generalized HIV epidemic, which is relatively of low prevalence of about 1.67%. However, same story cannot be said about our key population. Sex workers, men who have sex with men, transgender people, and persons who use drugs continue to be disproportionately affected by HIV. For example, we have our sex workers having a prevalence of 4.6% as per the Interbio Behavioral Surveillance Survey that was conducted in the year 2019. The MSM, which is the men who have sex with men group, have even a much higher one, which is 18.1% per the men study organized in the year 2017. For persons who inject drugs, there was a rapid assessment conducted by the University of Ghana School of Public Health. It was funded by the Global Fund through WAPCAS, who is a principal recipient for the Global Fund intervention in Ghana, and was recorded or estimated that the persons who inject drugs also have a prevalence of 2.5%. Next slide, please. Now, as a country, we have determined that stigma and discrimination, marginalization, and then low levels of HIV knowledge are the key determinants that is driving our epidemic. And how do we go about solving this situation? So as a country, backed by our national strategic plan, which the current one is within the period for 2021 to 2025, we have scaled up our HIV combination interventions for key population. And then we also have a KP SOP, which is a key population standard operating procedures, which also gives us guidelines on how to carry out our interventions. And through that, we are currently implementing more of a community-centered approach to our intervention. And with the scaling up, we are looking at social and behavioral change communication, combination prevention services, and also how to foster an enabling environment for our key populations. And the critical strategies that can help us that is helping us to do this is the use of the peer education strategy, which is a strategy that enables our key population to play an active role, putting the key population at the center of the implementation in protecting and sustaining their own health, and then empowering them to make decisions, modify behavior, and then change social conditions. Next slide, please. Yeah, so a lot has been said about peer educators, peer education from the first presenter to the second presenter. So basically, peer education is just a form of communication where we have the KPs being at the center of the implementation. You have a key population member, peer, who has been trained to motivate and influence their other colleagues or peers in how to maintain a positive behavior or undertake behavior change to improve their health and well-being. And this is done basically using the snowballing strategy, where you meet a peer and the peer exposes you to his social and sexual network, and then it goes on and on and on, and then you are unearthing a lot of sexual and social networks and then providing them with comprehensive HIV and AIDS and human rights services. Now, there are approaches to how we do our peer education. The peer educator on a normal day will do a one-on-one approach. That is a peer educator meeting a one peer and providing education and all other services that the peer desires, or a small group approach, which is getting people between 2 to 5 persons, and any other grouping beyond 5 is a large group approach. So as you can see in the picture, that's a sample of a peer educator having a small group session. Next slide, please. Now, the work of the peer educators basically is to conduct peer HIV. Is to conduct HIV peer education and outreach services. And in any of the approaches that will be used, whether a small group or as a one-on-one, a peer can be said to be reached if the peer has received HIV education and other STI information, have undergone a risk assessment or received condoms and lubricants, and then also referred for HIV-related services, and even in screening for sexual and gender-based violence. We have a minimum package of services, which is saying that the peer is supposed to receive at least 4 of the services from a peer educator to be designated as rich. But for us to be able to make sure that we are doing well in terms of reaching our fast-track targets as well, we, HIV testing services, as well as condom, that is giving the peer condom is a key indicator for us to designate a peer as having been reached. Next slide, please. Now, the roles and responsibilities of a peer educator. The previous presenters spoke lengthily about micro-planning. A peer educator has a role when it comes to micro-planning too as well. We make the peer educator conducts local mapping exercises to demarcate where we can call microsites. And basically, the microsite is a geographical area which has 1 or more hotspots and has enumerated KPs of between 30 to 60. So where a peer educator does these local mapping exercises, and we are getting, we do a contact listing, and then we have about 30 to 60 peers at that particular area, then the place can be demarcated as a microsite, for the peer educator. Also, where there are instances where a contact listing is done, and then you realize that the number of peers that are found at that particular location perhaps is more than the recommended number from our KPSO, which is a 30 to 60. In this case, let's say if you are contact listing, you are getting 100, the place will be split. The site has to be split, and you get other microsites from it, so that the peer educator can actually concentrate on their peers in order not to be overwhelmed by the numbers. Another key role of peer educator is about identification of the KPs, and then conducting face-to-face discussions with their outreach group. Yes, face-to-face discussion, but peer education has also evolved with the advent of technology. Now we have social media coming in, and then we have peer educators who use the social media to reach out to their peers too as well. And the key role of the peer educator is also in conducting risk assessment. It's in conducting risk assessment and also referring clients for HIV services, and then supporting gender-based violence survivors to seek justice also. So we have a cross-section of our community cadres or peer educators who have been trained with basic human rights and are pocket lawyers, excuse me to use the language as in quotes, pocket lawyers, and they seek for justice when it comes to GBV cases. Next slide, please. So now we are looking, the next slide, we are looking at how we implement peer education in a KP program. Yes, peer education, we've said, is very key. And knowing that the community is faced with a lot of hostilities, there's the need to conduct a community entry in order to make the grounds favorable for the work from the onset. So though we have a lot of agitations in terms of homophobia and other things, there are community actors, there are stakeholders, there are people in the communities who understand the need to provide services to KPs as a means of addressing public health issues. So some of these are the local administration, like the district assembly, social welfare. We have the Ghana Health Service, Health Directorate, and then we have even the Ghana Police Service. We have they have been undergoing training, so we have key people in there also that understand the need to work with KPs. So the first thing we do is to do a community entry to initiate and nurture and sustain desirable relationship. There was a classical case where in one of our districts we were there was a peer outreach going on, and nurses were there to provide HIV testing services. And in fact, it was a night outreach. And these this group of peer educators with the peer outreach workers were misconstrued as blood collecting ritualists also, and people raised alarm and they could have been beaten. In fact, the whole situation was very terrible. But for the good community entry engagement we did before starting the whole intervention in the district, the Ghana AIDS Commission, together with the DOFSU rep and then the district health director, they brought in the district chief executive, which is the government representative at the local authority level. And because we went to all these people, they came in and then they restored calm, that they are not bad people, that they are in to provide health services to the indigents. So when a good community entry is done, it even provides security assurances for the peer education, for the peer educators. Now, another purpose of doing a community entry is also to identify local community members, ringleaders, and influential community members, gatekeepers, and friendly health service providers to participate in the mapping of key population hotspots. Now, another benefit also is that when a good community entry is done, you're able to identify the hotspot and the suitable times for providing services, whether it's at night or a day time hotspot. And then we're able to also get M-Friends and M-Watcher. M-Friends and M-Watchers, the M-Friends, for instance, are people from the social welfare or SRAJ, that's the Commission for Human Rights and Administrative Justice. These are people who are friendly to the to KPs. They may not necessarily be KPs, but they are friends of KPs and understand why KPs also deserve to, they also have some rights. And the M-Watchers are also a mix of either KPs or non-KPs who are also there, who watch over our KPs for us in terms of sometimes crisis. So when doing community entry, we're able to find out those that are suitable for the formation of district crisis response systems, who are the M-Friends and the M-Watchers. Next slide, please. Yeah, so after the grounds have been set and stakeholders are informed about what we are about to do, the next thing we do is now to look at recruitment and selection of our peer educators. Now, how do we do this? First, one of the strategies is to advertise the vacancies using multiple mediums. That's by word of mouth. We use social media groups or forums that KPs are there, the community leaders or community actors that we met during the mapping exercises. We make them also recommend, and then we get suitable candidates for our prospective candidates who want to be peer educators. Now, the next thing to do is also to do an interview session. Now, in all this that we do, like I said, the community is put at the center of the intervention. So the community plays a role. So in the interview, for instance, a panel is constituted, and in the constitution of the panel, we make sure you have KP representatives who will also be in there to also help us to actually interview the prospective participants, and then the qualified candidates are selected. The criteria for selection include representativeness of the population, in that before you can be a peer educator, you must and you have to be part of the population before. So if it's an FSW, that is a female sex worker peer educator we are talking about, you have to be part of the community before you can be a peer educator. And then we also recognize the diverse nature of the the community. Some being high class, some being tech savvy and all that. So we try to bring on board all the various perspectives and how to factor all this in so that we have people that can reach peers across various divide. We also look at the size of the social network. Like we said, we use the social network strategy. You have to start from somewhere. So usually if they have some that have good social network, and when you start from with them, you go very far in terms of your implementation. Then the degree of respect among peers too as well. There are instances that you get a peer coming for interview to be a peer educator, and then the community will just let you know, this person can't be a peer educator because what? This person perhaps has history of being a blackmailer, or he has history of not being able to keep confidential information. You know, it is health records that we are talking about. So we look at all these things to make sure that you're getting people that the community wants, that the community can trust with their information too as well. And then the availability over the period of the intervention is also very key. We know KPs move in and out a lot. So when you are interviewing, the selection criteria is also that we look at people that can stay during the period of the intervention to help us achieve the objective. And then the commitment of the person who is to work as a peer educator is also very, very key. And not just the commitment, but the willingness to also serve the community is very key. Without this, you realize that the attrition becomes very high. The person comes today, he works for 1 or 2, by the time you realize, then he's gone because the commitment is not really there. So we look at all those, including personal traits and ability to lead other people. We look at all that. Next slide, please. Yes, so the next strategy we also look at is after we have now gone through the recruitment and selection process, the next is to build capacity. Yes, we know we saw something in them before, during the interview, before we selected them, but we now look at building them and equipping them with the requisite skills to be able to do the work. Now, to do that, we appreciate people coming from diverse backgrounds, and we don't underestimate anybody's knowledge. So we first conduct an assessment of the selected peer educators. This assessment enables us to know their strengths and weaknesses, and then it helps us to know how to design or retailer our training to meet the needs so that we can achieve the best objective from the training. Now, our training content also looks at topics that are on promotion of key health behaviors and how to use our educational materials, such as the use of the sexually transmitted infections, flip charts, and dummies for condom use demonstration, and even data tools that we'll be using for reporting, including how to go about micro planning and then using the micro planning tools. And then a key thing that we also do is to look at ethical issues. We take them through ethical considerations, which is confidentiality, power balance, gender equity, that are likely to arise in connection with their work as peer educators. And a key one we also look at is to take them through policies on protection from sexual exploitation, abuse, and harassment, which we call the SIA. And this equips them to be able to be ethical and do the work as professionals, because peer educators are supposed to be role models in their community. So we equip them with all these values. Now, the training approaches. In terms of training, we look at using interactive and participatory approaches. And when these approaches are used, it enables us to harness the potentials in them and then see where the shortfalls are, and we're able to fill in the gaps where necessary. And then we look at building their skills. Next slide, please. And in terms of skill building, we look at building 4 main key skill sets. That we look at. The first one has to do with their technical skills, which has to do with the understanding of the basic HIV and AIDS and sexual rights and reproductive health, and then human rights concept. That is the message that they will be carrying. So they need to be equipped with the technical skills to be able to deliver the message to the community, because they are in the community and they alone can do it best. The next thing also we look at is the facilitation skills, how they undergo the education and how they communicate and how to present the issues, even including how to facilitate condom demonstration sessions. We take them through all that, and then it enables them to learn how to cope also with personal questions, jokes, and disorder, and gives clear directions, guide debate and process activities. Another thing is also the teamwork that we look at. One man cannot do the work alone. Yes, a peer educator may be assigned a microsite that is working, but our KPs are not static. Today, one is here, tomorrow it is there. So even is there. So with the micro planning approach, where there is some movement, with the teamwork, you're able to realize, oh, this is my peer, and this is where I reach in terms of the services I was giving him. And since he's in your microsite, how best do we collaborate to, how do you call it? You carry on from there. So teamwork helps. So we build their teamwork skills, which they get to know that it is not a competition. We are working to solve a public health issue, and bringing their effort together helps. And then we take them also through reporting skills, which is also very critical, because if you do all the good work and then you do not report accurately, the data that we get would misinform us. We won't get the correct data to do to take accurate decisions. Next slide, please.
I'm sorry, Sanyu. Can I ask you to speed up a bit as you're remaining only with a few minutes left? Thank you.
Okay. So after taking them through the, after recruiting and training them, we engage them to start the micro planning process, which is basically, as the previous presenters have spoken about, it comes from the premise that we appreciate that every key population is unique and may have certain specific needs. So based on that, we are able to tailor services to each KP based on its needs. So micro planning basically is a process that decentralizes our outreach management to the grassroots level workers. And like I said, microsite is basically a geographical area that has one or more hotspots with 30 to 60 enumerated KPs. So yes, so basically this is what our KPSOP says, but in practical terms, it is sometimes very difficult to go by this, because you will start the intervention and then you have a microsite which has the desired number of KPs, all right, but as a result of the movement of KPs in and out, in a year, you may end up having a KP giving services or managing a little over either 100 or a little over 100 in a program year. Next slide, please. Yeah, so the micro planning tools, I think that my Kenyan colleague touched on it. So next slide, please. So the benefits of micro planning, we've said extensively, that improves data collection and reporting by tracking each individual KP, allows PUs to monitor who is due for clinical services, and it also enables PUs to identify outreach gaps, and it creates community ownership as well. Next slide, please. Now, after all the good work, they need to be honored, they need to be incentivized. So what we do is to provide incentives to them in the form of TNT allowances. Sometimes we give it's about giving annual awards and recognition, and we have a quarterly cash prize we give to them as motivation per quarter, especially on the Global Fund project. There's a quarterly motivation that we give to our peer educator, and this motivates them to do more, because for those that are having issues or that are not really committed, to see that there's some motivation in there to also get committed. Then also there's a peer progression plan. Now you can see we have a lot of our peer educators who are now field supervisors and our program officers. Some are even at the level of program coordinators. And with all this, it motivates them to take the work seriously. Next slide, please. Yeah, so about monitoring and supervision is also very key to get things going. So we have bi-weekly meetings where we meet with them to understand the difficulties on the field, the challenges, and how to surmount those challenges. We have monthly meetings also, and there are mentoring sessions that we go through with them. And then we have the key population members also participating in the monitoring and supervision. So we have what we call the KPMT, which is a key population monitoring team. They're also around to monitor how the intervention is being carried out by the civil society, by the how do you call it, the health workers, everything that is holding duty bearers accountable for the investments being made. And also we have the use of the WhatsApp live location, where we make volunteers to drop location so that we get to know what they are doing on the field at any particular point in time. And it also helps to make sure that there are security issues. Should anything happen, we know where a volunteer was at any particular point in time. Next slide, please. Yeah, so that the role of governments and then development partners and then NGOs. Government, first and foremost, is to formulate and adopt favorable policies that will create an enabling environment for our implementation. A lot of you will know that there's a proposed anti-LGBT bill in Ghana, which is making the terrain a little very difficult and is causing fear for the community. So government's role, for instance, is to make sure that there is that serenity in the atmosphere, or the environment is okay for implementation to go on. Government also is supposed to provide more resources for interventions, and then government also look at maintaining law and order, and then provision of health facilities and health personnel for our work. Now, for the NGOs, we have NGOs also providing resources for activities, training outreach workers, monitor and supervise field activities also, and liaise with the community to understand their key issues and their needs, and then getting them addressed, and also generate accurate data of outreach efforts to inform decision-making and to empower the community members in the project too as well, and also understand the needs of the community and initiate appropriate action. For development partners, provide funding in support of national response through financing partnerships, provide policy direction in aid of implementation, and supporting the procurement of essential health commodities. I know the Global Fund, for instance, supported us in terms of procuring flavored and nicely scented, colorful condoms for our MSM population for free. And it's for free. And this is good. UNFPA, that same, and all that. Next slide, please. Yeah, so in terms of the challenges, yes, our key problem in Ghana is the unfriendly social and legal environment for KP. In fact, the recent anti-LGBT bill being proposed in Parliament has made grounds a little tough, but in all that, as key implementers, we have how we are working to overcome this. We have safety and security training done, because when these things happen, it caused a lot of uproar, agitation, and people were on the lookout for KPs. But we have safety, security training, and we extended the same onto our peers in terms of pushing safety and security tips on their platforms and everything, so that they know how to carry themselves or how to in that time. So the unfriendly legal environment is a challenge. Intermittent shortages of commodities such as test kits and condoms is also a challenge. And stigma and discrimination, as you know it too, is a challenge. Where the laws are unfavorable, stigma and discrimination becomes very high. Yeah, and then unreliable outreach workers. For instance, peer educators sometimes do not feel committed because of the nature of the remuneration. In some jurisdictions, some would want it to be in a form of salaries where they can feel committed. So when you're having an implementation in a mining area, for instance, when you're in the Western region and you have implementation in the Tapa area, a peer educator would try to compare what he would make if he's supposed to do some form of illegal mining in the community, and then what he would get if he's committed to doing a program, and will start the work somewhere along the line, vanish. By the time you realize this person has found something else doing in the community to make ends meet. So in terms of our solution, saying that there needs to be an intensified advocacy against punitive laws, such as the proposed bill I talked about, advocacy for supply chain gaps to be addressed so that our shortages, intermittent shortage of commodities will be also resolved, and also intensify S&D trainings in health facilities and stakeholders. So for the S&D trainings, the PRs are doing a great job. They have trained all the facilities, but as you know we can't stop. We just have to continue doing more of the S&D trainings until the environment is favorable for our people. And advocacy for the salary-based remuneration, like I said earlier, is also very key. Next slide, please. Yeah, so I've mentioned these already, except for the better remuneration system for volunteers. Like I think I mentioned that one too, which is saying that some may prefer salary. So if we could look at that, it will be also of help for them. Thank you. Next slide. I think that's the end of my presentation. Thank you.
Thank you. Thank you very much, Senyo, for this presentation. Really, again, I think it's another great way to show and to talk about how peer education programs, really live at the country level. I really appreciate it. You spoke about well, two things that I really thought were really relevant. One is around the safety and security, and you also gave a very good example about it, and how important it is that not only we ensure that we provide prevention, testing, treatment services to key populations out there in the communities, but as we do so, we do it in a way that really preserves the safety and security of KP implementers, right? Especially if we want these programs to be run and led by community members. We have to be cognizant of the danger that our programs might expose them to. So really having measures to preserve this their safety is really important, and money, right, to support this type of interventions. The other thing that you mentioned that I really thought was important, and I would like maybe to touch on maybe the Q&A session, is actually also the and I think Parinita also mentioned it really briefly, is how peer education is changing with the advent of virtual approaches, with the fact that there exists a virtual reality, an online world where key populations also meet and encounter, and so it's important that we also make use of that opportunity of these new systems that exist today. Okay, so well, again, thank you very much to everyone. I think it was really great to hear from all our presenters, but now I think it's also important to give our audience a chance to ask questions, any clarification you want to have, any topic you would like to have a deeper discussion on. I think now it's the time. If you wish to speak, you just need to click on the reactions icon that is at the bottom of the screen. And when you click there, there is a possibility to raise your hand. And if not, you can also just simply, I believe, unmute and try to speak. I think that's also a possibility for you. Let me stop here and see if there's any question. Trying to monitor the chat as we do so. I see there is a message from Gertrude Nuno, who's also thanking for the excellent presentation, Senyo. So really great to see that. I don't know if there's particular questions that anybody would like to ask. As I said, it's quite a dense topic, in terms of the various different, aspects of peer education that have been touched throughout this, almost 2 hours, I would say. I'll keep on speaking in the sense that until there is a question, but please feel free to interrupt me anytime. My personal feeling, also from what I'm sitting here at the Global Fund, is that peer education is becoming really important, because also our job is becoming, if you want, also more difficult. Like we're really have to evolve and transform our community based strategies to provide services to key populations, with key populations, because maybe the low-hanging fruits, so-called low-hanging fruits, probably have in most countries that are implementing or have been implementing KP programs for a while, those low-hanging fruits have been reached, and now it's really a case of finding the people who are really the most marginalized, even among key populations themselves. And so this requires, us really being able to tailoring as much as possible our services. And that is why I'm thinking that, even virtual interventions, can really help us do that, right? Obviously, going online implies a number of principles, new principles even, that we really have to take into consideration. And for instance, safety and security, but also ensuring that we use ethical approaches when trying to reach people online, for instance. Another important aspect that I think we really discussed on today is the remuneration. We see that a lot of the presentations touched on it, and how it's important that whatever is done as much as possible is standardized, right, across donors, across implementers. Otherwise, you risk seeing peer educators, jumping, from one program to another. It's also important to remember that, there are different ways of remunerating peer educators, outreach workers. There really needs to be, in my way, in my thinking, at least, tailored to the type of work that is done. Working 5 days a week, for 8 hours every day in a peer education outreach program is different than dedicating 1 or 2 hours every day to it. So even the remuneration should be able to reflect these differences, right? So I think it's also important that we acknowledge that, and we try to be as nuanced as possible, right, and as contextual specific as possible when we plan our peer education programs. I don't know if our colleagues from SSNL see any particular question. I'm thinking specifically if there are in the audience participants from some of the countries that have been, if you want, that we try to address this particular session to people from South Sudan, colleagues from Nigeria or the Republic of Congo, or even Cote d'Ivoire. If you have specific aspects of today's presentation that you would like to clarify, or thinking about the upcoming funding request process, if you have any particular questions or idea in relation to that. It looks like there are no other questions in the chat or comments. I'm going to seek advice from our colleagues at the SSNL. I see we're projecting 8 key takeaways.
Yeah, I think this, thanks, Matteo. I think this Link and Learn was specifically organized for participants from South Sudan, Nigeria, Republic of Congo, and Cote d'Ivoire. So I think, like you said, we would really like to hear from them what their takeaways were, right? I mean, what is it that they could? Of course, I see David's hand, Matteo.
Yeah, please, David, take it away.
Yeah, thank you very much. And good afternoon from Nigeria here. Nice presentation from the two countries, for the ones I listened to. Now, my question, the what I didn't get from the presentation from Kenya and from Ghana was the specific roles of these peer educators. Is it only HIV education involved in testing, HIV testing? Are they involved in all that things? Because basically what I just heard out from them was around HIV education and condom and lubricant programming. I didn't hear much about HIV testing services and then linkage to care and all that. Over.
Thank you, David. So David is basically asking us about the package of services that is being provided by peer educators and outreach workers, depending in Kenya and in Ghana particularly. I think the question is, do they provide, on top of providing condoms, creating demand for condoms and lubricant and distributing them, and also providing information around HIV, do they provide other services in particular is inquiring about HIV testing, either I believe on site, in a community site, done by peer educators, but also by referral to clinics. I don't know who wants to take this question. Can we start maybe with Senyu, if you want to maybe talk about Ghana first, and then we can ask also Memory to chip in from Kenya. Thank you.
Okay, so thank you very much. So with the role of the peer educators, after providing education and then also creating demand, that is for condoms and lubricants, they also create demand for HIV testing services. And based on which, if after having done a risk assessment, a peer is required to do an HIV testing, the peer then is referred for HIV testing services, which the testing is done either through a community, that is an outreach, testing outreach, or a direct referral to the health facility or to the DIC, the drop-in center. Now, where there is also a barrier in terms of cost barrier, our programs provide peer-led services, which are TNT support, to also take the peer to the facility or to the DIC to also get testing services. But in most cases, we bring the testing services closer to them in the communities by doing outreaches. And then as part of some of the, aside the HIV testing, they also do screening for gender-based violence, and then refer clients appropriately where they identify some intimate partner violence or any other abuses for services. My colleagues are also online, and I think they can add on to some of these services as well. Thank you.
Thank you so much, Senyu. I don't know if Memory, you would like to give us also a few maybe examples from that you're aware of for outreach programs in Kenya.
Thank you so much. So it's not any different from what Senyo has talked about, but of course, on top of that, currently we have mental health guidance, and the peer educators are actually also able to screen their peers for mental health, being that we noted that a lot of key populations are facing mental health issues. But when it comes to linkage, of course, after creating demand for health services, of course, you have an array of healthcare services that we offer to our key populations as per the guidelines. After creating demand for the healthcare services and ensuring that they are referred to the healthcare providers, when it comes to linkage, of course, it's the HTS provider who is supposed to be conducting the HIV testing. And it's still the role or the mandate of the HTS provider to ensure that the HIV positive client, for instance, is linked to care. So at that point, it's no longer the role of a peer educator. Thank you.
Thank you so much, Memory. And really, if I can allow myself to also contribute to the question, because I really think it's an interesting one. I think a lot of I think is in specific relation to HIV testing, it really depends on, and if peer educators can do that, it really depends on the national testing guidelines in countries. There are countries like, for instance, Mozambique, where peer educators have been trained in KP peer educators have been trained as HIV testing counselors. So they also are capable of, themselves provide HIV testing, even at beneficiaries' homes, and be in charge with linkage to prevention services or to HIV treatment, depending on the result of the test, right? So that's also something that you can have, but it really depends on what is allowed in the testing guidelines. I see there's some discussions also in the chat. I'm trying to see if there is any particular question for one. I see there's a question around the tools from Babatunde Adelekan. which tools were used to track services, particularly in relation to community outreach, condom distribution, and utilization. I think there's a bit of a question around monitoring, right? And so what are the particular tools that are used? I don't know, Senyo, if you want to start answering this question, maybe talk a bit about how do you measure, the number of key population beneficiaries that are being reached, and which tools you use particularly. Thank you.
Okay, so I have on the call my my boss, Kofi Diaba, and I think he would help us with this one. Thank you.
Absolutely, thank you. Please. I think we're waiting to hear from the manager of Maritime Precious Life Foundation around M&E tools.
Can I go ahead?
Yes, please. Oh yeah, go ahead, Memory, in the meantime, yeah.
Okay, for us in our Kenyan setting, the main tool that you use at the peer education outreach level to track for services is what you call the peer outreach calendar. So, of course, it's a tool that has a line list of all the peers that is under a particular peer educator, and then really tracking the services that are offered to the peers on a monthly basis, ranging from the condoms, lubricants, needles and syringes, as well as those who are referred for clinical services and any of those reporting violence. So as you have a tool that is called peer outreach calendar, that is in use. Thank you.
Thank you so much, Memory. And, just to say that what we see also here from the Global Fund is that, in terms of monitoring services being provided to key populations at the community level, the big differences between monitoring systems and tools that are capable of tracking, if you want, groups in terms of, knowing how many, for instance, MSM or how many sex workers have been reached with a defined package of services. So we collect that information, implementers manage to collect that information. And that's one way. And then there is another way, which I think is, I would say, more sophisticated because it requires more sophisticated tools. It's really the ones that are capable of, using a system that uses unique identifier codes that identifies each beneficiary. So by using of this code, you're capable of telling how many times, for instance, a sex worker has been accessing services through this program in a year time, for instance. And depending on how sophisticated the system is, you can even know what type of services this person has accessed, how many condoms this person has received, and then, how many times testing was offered, and then, used, and then even the result. And then you can also follow this person through the whole continuum of care cascade should the result be positive, for instance, right? So you have a number of tools that exist, but I would say the main divide is between systems that are UACs enabled and systems who are not, and both have their pros and cons, right? Just to be clear. Yes, I see your hand, David. So please take it away. In the meantime,
thanks very much.
Thank
So
you.
the question I have for them is the two things. In Nigeria, we used to have these sessions, these peer education sessions separately, and then you have a different set of people testing. But Global Fund and PEPFAR, I felt that was very, very expensive, because then you will have to provide refreshments during peer sessions to them, which was very expensive. And the same people now will not come around again for testing. And then there are a lot of missed opportunities between the time of the peer education sessions and then the actual testing. So we combined the two, and our peer navigators are trained for counseling and also for testing. And of course, they accompany the clients to the OSS or a drop-in center or the CAT team for enrollment for those who are reactive for confirmation. What did they do that made Global Fund or PEFA to accept just peer education sessions alone in these countries without combining it with other services. So having a standalone peer education session, is there something they did? Was it the way they put it there that they accepted? Because right now, what we do now is that we combine everything together because of costs. Over.
Thank you so much, David, for this. I don't know if anybody, either Memory or Sanya would like to try and answer the question, but I think, I think David is posing really a good question in terms of, how what is the feasibility of integrating services versus the costs, and and how can we do that? I don't know if anybody would like to take this question. I see we're almost, actually we are at time now, but maybe if there is a short wisdom that you can provide, we're here. Pari, I also see you have your hand raised.
Yeah, I think it completely. I mean, even peer navigators are community members, right? I think that's what I understand from peer navigators, or that's what the WHO guidelines say. But I also feel that it's also completely depends on what community feels comfortable vis-a-vis what budgets we have sometimes, right? Because we have had many conversations. Like I've had conversations with some of the Kenyan community members, and they are not happy for community members to follow them up if they're HIV positive. They feel that confidentiality won't be maintained, and they want clinicians to follow them up or counselors to follow them up. So I think it depends on what works for the community and how it works for the community. And I think consultation with the community is important. And I think what David is saying, if it works with the Nigerian community, well and good. My only concern would be peer ratio, because when a peer educator or peer navigator is expected to do so much of work, then what is the peer navigator versus peer ratio, and what's the remuneration that you are paying the peer navigator? I think those questions can be talked about, but they should be compensated for the work that they are doing, and sometimes when we overload the peer educator with so much of work, I wonder if they stay as peer. Do they get a chance to go to the hotspots, do sex work or cruise or whatever, right? So I think it's a matter of balance and what community wants and what community prefers in our context. So I don't think it's a right or wrong answer, but I think what's good about whether it's a peer navigator or a peer educator is that we are engaging community to reach community, and we are empowering community. I think that's the beauty of it. Thanks.
Thank you, Pari. And if I may add, I mean, I think that, particular situation, particular context, it might be good also to remember that peer navigators do not necessarily need to be the same as peer educators. You may find it easier, for instance, to have peer navigators, especially if you're looking at the HIV continuum of care, to have peer navigators who are themselves HIV positive to help guide other KPI members who are themselves HIV positive through the system, right? Because there's another level of trust and another level of stigma that we need to remember exists. So it's really important to take that into consideration. Always remembering the general rule that the higher the peer ratio, the less effective a program becomes in terms of intensity, right, and frequency of contact, which is really our golden standard, I would say, in KP programming, especially for the people most at risk. And with this, I guess we will, we've come at time, I believe. So I would like to thank you all really for staying with us throughout these 2 hours. And thank you so much for our presenters. Thank you, Parinita. Thank you, Senyo. Thank you, Memory, really, for sharing your knowledge with us and also your experience. And this is it. Thank you so much, and looking forward to the next Link and Learn session.
And thank you, Matteo, for facilitating us. Wonderful.
Thank you. All right. Bye-bye, everyone.
Mo, if you are showing a poll, it's not coming up, at least on my side. I can't see a poll. Have you loaded it? Yeah, it's come up now. Thank you.